everybody's kind of getting ready to get to adopt MATTERHORN in their practice. I think patients will be reading about this. I think it's going to be hard to know what to do with patients who are already on therapy, right? And they're like midway through treatment. But what do people think? What if somebody already went to surgery? Would you give adjuvant durvalumab if they have not received it in preoperative setting? Because that's the real world questions we were going to get next week probably from our patients.
You ask all the difficult questions.
No,
I should probably defer.
Yes.
The most important part. The most important part yesterday was to get it out and hopefully get regulatory approval. Because again, we already adopted it after I saw the PCR rate and at GI ASCO. But oftentimes we would get pushback. So coming back to your question, D-FLOT, yeah. But we get only approved for half of the patients. But hopefully now we get it for everybody. So coming to your question, now those poor patients who started, not at UC Irvine, but other places, chemo alone and they're post-op, will we be able to get it through insurance, commercially. But as you know, the benefit of adjuvant checkpoint inhibitor in resected gastric cancer is doubtful in terms of overall benefit. So that would be a hard discussion with the patient and the payer and then see if it's worth it or not.
I don't feel very enthusiastic about doing it. Again, I mentioned that I like it, the neoadjuvant. There's some biology and goes to other tumor types also. In the adjuvant isolated, giving them, unless they have like something like MSI high or something, maybe yes, I will. I mean, these are patients high risk of recurrence anyway, but I wouldn't do it in a regular sort of way.
Well, that brings me to another difficult study to discuss. We can start with Vince now. CheckMate 577, right? I think the radiation oncologists will be quoting us that data to make sure we still continue to use chemoradiation. Can you just summarize maybe in a few words what we've learned during this meeting?
Sure. So CheckMate 577, as everybody knows, is really the randomized phase 3 study that looked at the addition of adjuvant nivolumab post chemoradiation, and previously shown to have a significant disease-free survival benefit, 22 months compared to 11 months with the control arm. And at this meeting, the long-awaited overall survival endpoint was disclosed, and it did not reach statistical significance, so there was no overall survival benefit, although numerically, pretty significant. I mean, a notable difference between, with the addition of nivolumab, but overall, no overall survival benefit with the addition of nivolumab. Interestingly, the other bit of data that we were looking for was the PD-L1 subsets, and we're grateful that they showed that, and it confirmed what many of us thought and have seen multiple times over in the metastatic setting, which is if you don't have the target, I guess especially in this adjuvant setting, an anti-PD-1, PD-L1 may not be effective. So, my takeaway from this is that if you have a PD-L1 negative patient, I would have a low threshold to not start adjuvant nivolumab.
Although tricky, the study I think is tricky because both adenocarcinoma and squamous cell cancers are involved, so it makes it more complicated to decipher the results, and we have not seen separate Kaplan-Meier curves for both. And PD-L1 is dynamic biomarker, at least in early settings, it can change with radiation, so I think it's tricky to know exactly when to test and which number to use, right?
Yeah. No, that's a really important point. I'm glad you mentioned that, Nataliya. I mean, I should amend that to say, for squames, I would definitely consider adjuvant nivolumab as per the current standard of care. Since we do know that squamous histology do respond generally better to anti-PD-1, PD-L1.
What about patients who had crossed over down the road? Like patients who did not get the adjuvant nivolumab and then had recurrent disease, and they got immunotherapy. That would have blunted the difference between the two curves, right?
Yeah, from what I remember, it was a small percentage of patients who received subsequent. I thought it was close to 20%, but we might need to double check on this data because the data is new. So,
yeah.
But what about you, Jun? What are your thoughts on the data?
I think it's, I agree with Vince, it's very clinically meaningful, the overall survival numbers they showed. I don't think it steers too much away still from FLOT, at least in the adenocarcinoma realm, given the mix and the heterogeneity with the squamous cell population in that study. But I agree, I think it reassures that for squamous cell carcinoma, it is still probably the default way to go for treatment with chemoradiation.
Now, we don't see a lot of squam anymore in the US, at least at our institution. But it doesn't mean there is no phase 3 data looking at that question like ESOPEC. There's a large randomized phase 3 out of Japan that compared chemo doublet, CF, with a triplet chemo doublet with chemoradiation. Now, triplet chemo was better than doublet chemo, and doublet chemo was the same or slightly better than chemoradiation, and it was purely ESCC. So I think we do have the data. I'm not sure why we say for squam we still undertreat them. I think squam actually is a very aggressive disease. It might respond better to radiation, but you still need very good systemic control. So I'm not sure perioperative or TNT with the triplet chemo as tolerated plus IO would be wrong for squamous cell cancer.
I think it's hard. I agree with you saying, and I actually discussed that data at GI ASCO a couple of years ago, which is why anyone could know the study coming from Japan with DCF. But I think we have to be careful with translating data that's done in a different country to patients that we see in the US. It might not be applicable. Toxicity of these regimens are different. And I think one thing in favor of nivolumab, Dr. Kelly has shown that adjuvant nivolumab did decrease the risk of distant metastatic recurrences. So it does have systemic effect. It's just in contrast to what we talked about with D-FLOT. We are not attacking micrometastases early, but it seems to be providing benefit even in adjuvant setting. It does sound like I disagree with Farshid a lot, but I think we agree.
I think we're speaking the same language.
We agree. Just saying different facts. Yes.
But we have to be. I mean, we have to be careful. I mean, I live in Detroit. I mean, he lives in Irvine. I mean, I was dealing with different kind of patients.
Yeah, Farshid, you probably see. Well, I guess, and you, Jun, you probably see more true gastric cancer patients, because we see, at least in my practice in Midwest, it's a lot of patients with GE junction. And I've said multiple times during this meeting, there's no such true esophageal adenocarcinoma. Doesn't really exist. It's distal esophageal, GE junction, proximal gastric, the same biology of the disease. What kind of patients do you see?
Yeah, and that's a very important question, because our demographics, 40% Hispanic, 28-30% Asian. So we have a lot of distal diffuse type gastric cancers, and the biomarkers that we see is very different, right? We have far fewer HER2 overexpressed, far more Claudin 18.2 positive, 90% PD-L1 CPS positive. So that's a very, very important question. Where you practice, what do you see? Mm-hmm.
Yeah, here in Los Angeles, I agree. We still have a big population of Hispanics. H. pylori is a big risk factor here. But actually, I have several esophageal squamous cells cancer patients, and they're all Asian. They were all treated with chemo-rads in complete remission. So it's quite highlighting the radial sensitivity of these patients.